do think we need to make that argument to national governments, and also, yeah, if there's a case to be made for the Global Fund still keeping some money in regional initiatives to deal with concentrated epidemics or in multi-country efforts that reduce the transaction costs.
So who owns that advocacy agenda? Who is owning it now, and do you think there's a role for organizations like that?
Definitely. I think part of the role, though, is to sort of strengthen the economic argument to countries, to just make the case for how well-targeted prevention can make a large difference. Yeah, and I mean, I'll send a batch of slides that we did as part of a Pakistan assessment. We will actually be working in Sindh in all likelihood in Pakistan, and Pakistan is not completely non-federal, so you can only work at the provincial level, which is, as you know, really difficult for donors. But just some careful mapping work with the University of Manitoba and partners. Basically, 70 to 80% of all the vulnerable populations are in 3 or 4 Pakistani cities. So you're not necessarily talking of a national program with rural outreach. You're talking of some really well-targeted and cost-effective things you can do.
So, you know, on that, even within sub-Saharan African context, do you remember Helen Jackson mentioning sort of 28% of HIV prevalences in these 14 cities? David, I'm a little embarrassed to ask you this, but we've looked for specifics of the cities and the evidence online everywhere. It's not in the public domain, apparently.
And it's a little shaky, I think. I remember discussing it with Mark Sterling. I think Marilise has some of that data, at least some of the charts. We can send it on.
We would really appreciate that.
Not completely convinced, but I haven't seen it closely enough, because if you take South Africa, you know, a lot of the epidemic is in rural KwaZulu-Natal, as you know, which would counterbalance a lot of the urban cutting.
That's true. Shaky. That's good to know before we focus on the rest of
I would look a little more closely. I think the case is clearer in Asia and elsewhere.
Yeah, I mean, happily we always do use established evidence at PSI, but it's been sort of floating around the team for some time now.
And the other opportunity, apart from urban, is you have really good examples in Kenya where we know that, you know, the Luo is 17% of the country's population and 51% of HIV infections. And in Nigeria, we also know that about 75% of infections are in the banana belt of 6 states. And that's pretty well grounded. And I think, a good basis for more focus.
Just coming back to concentrated epidemics for a moment, which countries do you think could be used to illustrate that point, that very little money is needed to achieve that? Any that stand out that haven't already been done to death, like, you know, Thailand's?
I mean, Malaysia is a really good example. Look closely at it. It's got one of the largest per capita drug-using populations. It's got quite a high prevalence in its vulnerable groups. It's middle income, it can afford to do these things. It is paying for a lot of the treatment costs. It's an obvious case. I think Indonesia is a pretty good case. Where else in Asia?
India, you mentioned.
India's a great case. India, in a sense, the argument is one. You know, the Indian government is putting
a lot.
It's funding its program adequately.
And what do you think from that experience were the key successful messages that stuck with the Indian government that we could consider in our advocacy efforts? Not to suggest that we would have any level of influence that would exceed that ranks, but if there are some successful messages that...
I think all of us getting our messages together on India are good. I think writing up what they did right, and they actually ended up doing nearly everything right. Just an example I always give. The last country I was in was India, because we were just completing our new 5-year program, and we'll be the last external funder of NACP4. Not that we're huge, but I spent a lot of time in the NACO offices and with NGOs, and you know, what just struck me blindingly was how much more intelligent and smarter India was than it was 10 or 15 years ago. The pace of just the intelligence and this, you know, you talk to NACO officials who are world class. You talk to NGOs who are world class. I mean, you talk to sex workers and programs who have more program knowledge than you would find in many places. So I think just the intellectual openness and the intellectual dynamism of India is really helping. It's a really smart place at the moment. You know, the brain power is being unleashed. And that's made a lot of things easier. I think my other points would be India got all the architecture right. I think having a NACO that was within the Ministry of Health but distinct, having state aid societies with IAS officers who could actually make executive decisions, and establishing a mechanism for contracting NGOs on a large scale. You know, and the Ministry of Finance did a review and they found that the best managed, least fraudulent sector of India's health response was its NGO contracting of AIDS partners, because the architecture had been developed right. And I always use this example as a humorous example, but take Brazil, which is another brick. In its own way, it does a lot of things really well. But I went to an MSM organization in Rio, and this organization receives money from the Rio municipality. I bet none of you know how that money goes from the Rio municipality to a Rio MSM organization, literally 5 or 6 blocks away.
Via international wire transfer?
It goes via UNESCO.
Oh, that's
And then you compare India's ability to simultaneously subcontract 1,000 NGOs, distributed in the right places, concentrate where the transmission is, and to take intelligent decisions. India asked the bank, and we'd argued for this, and we were so grateful to our procurement officer, that they did not want to rebid all their NGO contracts when the contracts transferred from Gates Foundation, from Avahan to the bank, because we've got a pool now with the government on the target interventions. And we really had a really smart procurement officer who got the point. And essentially, I think the argument was losses in efficiency, the opportunities for corruption would be so much greater if you rebid all these contracts. So essentially, they'll be continuing to performance manage them, but not rebidding them. And, you're talking of thousands of contracts that have been intelligently managed. So I think there's so much to write up in India. Just to continue it further, I think just India's willingness to trust civil society as a really major partner and to listen to them is different to where it was 15 years ago, where there was suspicion.
Which is fascinating. You think that we're not exactly low on the corruption index, right? And when you mentioned that it's more intelligent than it was 15 years ago, I've just written myself off. No offense to my other Indian colleagues.
But you must have, right? But it's when you go there, you notice it, don't you think?
Totally.
Yeah. I was, it's gone from being a Dodishan country to being a Technicolor country. It's intelligent.
Should we be worried about you, Krishna?
Always. Darshan is about the most painful national channel.
And it's all there was 15 years ago. Great. The other point, if colleagues here have worked elsewhere in Asia or China, if you go to an NGO in India, they do microplanning, they map their zone, they allocate peer educators per zone. Each of them have got a number of bars to look after. They've got behavior change materials, they know how they do it. Always use China as a comparison. Huge investment in hardware after SARS, so brand new buildings, whatever part of China you're in, no matter how rural. But the prevention program consists of a CDC in a county of 3 million people. They have about 5 peer educators of drug users, 5 as sex workers. You ask them what they do, they say they educate people about AIDS. You ask how, well, we tell them. I've never seen, and India structured a national prevention program. A PSI program, by the way, in Yunnan may be different. But I'm not sure. The national programs I've seen, that's how they are.
If I may, well, we tried, there are sort of state-imposed constraints in that country. If I could quickly ask a couple of policy-level things that we're grappling with, I mean, any suggestions, advice, etc. One is needle and syringe ban.
By USG.
Any advocacy efforts around that at the donor level? Is it even real to imagine that there will be some sort of momentum ahead of the global conference? That's one. The second is any suggestions, any recollection of amazing African organizations when it comes to dealing with homophobia?
Outside
and there was
South
a third that I can't remember right now. Outside of South Africa. So I'll start with those two, and I don't know if Nene or anyone else has any HIV questions.
Quick jump into those questions. Remind me of this again. I was trying to focus. Easy. I think part of the issue with needle syringe programs is, firstly, I think it's an area where I wouldn't try and put too much pressure on the US government. It's something we do discuss a lot with Eric Goospin. He always says he's fighting every day to protect his whole PEPFAR program and his whole treatment program, and so far successfully. And you know, there's not a lot of bipartisan support for needle programs in the US. So I guess where I'm going with this is what has worked well in the past is that when the bank has had programs, we've always been able to provide needles, and we're actually doing that in partnership with USG now in the Philippines and in India. They also don't cost very much.
No,
So if they're private foundations, private donors, if you can apply discretionary money, I guess I'm saying that I wouldn't focus on the US. They've got enough issues to deal with. This is really the only major donor standing.
Which
yeah.
is part of the problem, but perhaps explore with the Europeans or, as
Yeah.
you suggested, private foundations.
And also, in many cases, the principal barriers to needles are not cost. It's the policy barriers of being caught with them, etc. Yeah. So I think if you had a better policy environment, you could probably market needles at cost without greatly reducing program effectiveness. Yeah.
And homophobia?
I think the person who's been great on it outside South Africa is Botswana's former president, Mohai. He said some marvelous things. Our former World Bank Vice President, Joy Pumapi, was his health minister for many years. So Botswana's got some really great examples. In terms of a country that I think also just keeps getting smarter and is one of the smartest AIDS programs in Africa, for me, Kenya is remarkably open in these areas.
But the Prime Minister recently made some comments
Right.
about all gays should die or something
Right,
like
I said that.
Uh-huh.
I am sorry I missed that. The nice thing about Kenya, though, is it may not change what's actually happening on a day-to-day basis. You know, they're still pretty open internationally and domestically about how we've just worked on a mapping of MSM in Kenya, done officially with the government, a lot of openness, they have programs. Yeah, I missed Growler's remarks, I'm sorry about that. I still think they're likely to still be quite a good example.